Good evening, and thank you for joining us. My name is Dr. Jake Breeding, one of the general surgeons at St. John's Health here in Jackson. And along with me tonight, I have my partner, Dr. Eric Wieman, and Justin Grube, our physician's assistant that works with our practice and surgical patients as well. Eric, tell us a little bit about yourself and how you became a general surgeon and ended up in Jackson.
My father was a surgeon, and I knew that I was going to be a surgeon at a very young age, and I went and did my training, and did a fellowship in interventional endoscopy and pancreatic biliary surgery in Louisville. We practiced there for a few years, and we were looking to move out west. We've moved out 4 years ago, and everything's been great since.
Awesome. Justin, how did you end up in Jackson and end up working with the general surgeons?
I grew up in Wyoming. I was born and raised in Rock Springs, Wyoming. Went to the University of Utah. I've always been interested in medicine and ended up going to PA school in Philadelphia, at Philadelphia College of Osteopathic Medicine. Got a job in Vail, Colorado, orthopedics. It was a good learning experience. Moved to Jackson 2012. Did orthopedics for a while, and then I've been working with the general surgery crew for the last couple of years.
Awesome. Well, I came to Wyoming from Kansas, was born, raised, and trained in Kansas, and I joke with a lot of folks that I waited 45 years for mountains to spring up in Kansas, and when I saw that that was not a possibility in my lifetime, it was time to move out west to Jackson. I grew up around an agricultural background and a lot of farming, liked to work with my hands, and I saw that general surgery was kind of a natural extension to the things that I like to do with my hands, but it was also a good opportunity to meet people, diagnose a problem, and fix it in a short amount of time and really see the results of what I was doing pretty rapidly. And that's a big part of why I enjoy general surgery. Eric, you want to jump in?
Yeah, so tonight we're going to talk a little bit about colon cancer screening in the time of COVID or coronavirus and some of the effects of the lack of screening that have occurred and the ultimate outcomes related to those effects of coronavirus. And really start to talk about some of the strategies that we need to do to address these screening deficits. In particular, we'll be looking at some of the issues related to increased mortality and morbidity related to delay in screening secondary to the current pandemic. This is a graphic of the screening decline in both breast cancer and colon cancer. The blue is in colon cancer and the red is breast cancer. It actually shows quite acutely how in March the screening decline, basically to zero, and how some of that decline has resolved a little bit. But even with such a small decline over such a short period of time, we're going to kind of demonstrate the ultimate outcome of this lack of screening. And you can see that the breast cancer screening rates are much higher in general than they are for colon cancer. Now this is a nice graphic of basically invasive or non-invasive methods of screening for colon cancer and the number that were done during the middle of the pandemic, and you can see basically that endoscopy stopped for a brief period of time, and non-invasive testing like FIT testing or Cologuard testing was the only method available. So not only have you seen a decline, really, we'll see a decline in newly identified cancers during that period, not just colon cancer, but breast cancer, the lung, pancreatic, and gastric cancer. But you can see that the decline in colon cancer identification is basically halved, which is disturbing. It's not that the cancer has gone away, it's that we're just not identifying it. By not identifying it, you're going to, by the time that you will identify that the patient has cancer, you're going to identify it at a later stage, which is much worse for the patient. The prognosis for colon cancer is directly related to the stage, so if you identify it at a later stage, the outcomes, your 5-year survival, morbidity, and mortality are going to be significantly worse. And so based on this lack of screening during that period of time, they've been able to look at projections of how cancer rates are going to increase over time or over the next few years. And it's actually very disturbing. You can see that breast cancer, which is traditionally a little bit more aggressive, you're going to have a more rapid acceleration in breast cancer. And in colon cancer over time, because it's a little bit more latent than most breast cancers, that's actually going to outstrip breast cancer. This is a really excellent article in the British Journal of Cancer that addresses some of the strategies to deal with the deficit in colon cancer screening during the time of coronavirus. So really they looked at the per 100,000 people mortality rate and how that will change based on some of the screening strategies. So if you basically have no catch-up period, or you don't catch up with those colonoscopies that were not done during that time, then you're going to continue screening. You'll see a little bit of an acceleration rate. If everybody is delayed, you're going to see a maximum rate of increased mortality. And then if you have a delay in the first cancer screening, you'll see also a significant rise. And then, sorry, I just can't see the last one. And then you look really at whether the patients are going to have prolonged screening after the normal age. And what that means is, let's say that you have someone in the general population who is 78 or 79 during coronavirus, and we generally the guidelines are you don't screen over the age of 80. And if that person didn't get screened, it's not that that they're less susceptible to getting colon cancer. That person just didn't get screened. And now that you're over 80, you just basically didn't get your screening, and you're still very susceptible to the same risk factors as before. So it's not like you've escaped the screening window, you just haven't been screened appropriately, and that actually causes pretty significant risk of elevation in overall mortality. This is a nice graphic that shows over time how these strategies will affect the ultimate morbidity and cancer rate or mortality, cancer rate per 100,000 people. And you can see that it really is very significant based on the strategy. So not only do we have to catch up, we also have to prolong the screening period for those people who weren't screened, who are now out of the window for screening. You can't just pretend that because you didn't have that last screening that you're okay. You're still at risk, and these numbers kind of validate that. This is a nice graphic from the ASGE that talks a little bit about the numbers involved that we're looking at. So, 4,500 cancer deaths, basically 20,000 missed colonoscopies, and the ultimate outcomes. They also give a nice kind of strategy for developing a screening protocol. So I'd encourage everybody to look at that. So in general, colon cancer screening guidelines for average risks is 45 and older. Screening should be extended beyond the age of 80 for those who are healthy enough, for the people who did not get their colonoscopy during the time of COVID. Because just because you didn't get it because you missed it doesn't mean you still shouldn't get it. Now, if you have a positive family history of colon cancer, the general guidelines are 10 years below the age which they identified cancer in that relative. For specific questions, you should really speak with your surgeon to discuss what's right for you. We have a little bit of a patient video now from one of our patients here at St. John's. Talk a little bit about his experience. He's a great guy who was diligent enough to get his colonoscopy in the middle of the pandemic. So we'll listen to what he has to say if we can go to full screen.
Hello, my name is Jamie, and I'm 51 years old and a resident of Jackson Hole. I'm also a cancer survivor. In late June of 2020, I scheduled my first colonoscopy. The prior February, I'd been with my father and holding his hand in a California hospital as he passed away from his battle with cancer. Our last evening together, I asked my father if he had any regrets, and his answer was very simple. He told me he had no real regrets for any moment that led up to this one, but his only regret was the moments he was going to miss moving forward. I returned home and I felt responsibility to myself, to my wife, to my amazing daughters, to give us the best chance for every moment yet to come. My wife and I prioritized our health, and we scheduled our colonoscopies. My wife was clear, but I received a call from Dr. Wieman. Dr. Wieman was honest and positive. He believed I was one of the lucky ones who was catching this early. and we had a plan. I went through the weekend with no idea if it was elsewhere in my body. I felt the weight of telling my wife and children, but all the while I felt positive that this was caught early. I was supported, I was confident, and Dr. Wieman had said to me, "This is why we do colonoscopies, to save lives." 10 days later, I walked out of our hospital here in Jackson after Dr. Wieman had removed a section of my colon. I walked out of the hospital cancer-free. The early detection had given me and given my family the gift of many more moments. The colonoscopy was easier than I imagined. The surgery was a no-brainer, and I had a full and swift recovery. My care was kind, respectful, and comforting. What do I want you to know? I want you to know that a colonoscopy should not be put off. It's a simple way to give your family, your partner, your children, and you more moments. The alternative is unacceptable, avoidable, and it starts with a phone call to schedule yours. Some people might be afraid they might get that same call I did, but if you do, wouldn't you want to catch it early? Wouldn't you want every opportunity to kick cancer's butt? If I'd waited, my story, my future moments, all would have been in jeopardy and would have been very, very different. So pick up the phone, schedule yours. It's so simple, and you and your loved ones all deserve having the opportunity to make those future moments just amazing. So please pick up the phone and make your appointment. Thank you.
Yeah, that's a great story from Jamie, who just got back from his trip at the Big Island. So
Awesome.
Nice spring break. This is a great program. Kelly Sugarman, we had a great event last year. We were able to have a ski night here at Snow King, and many people may remember the large inflatable colon, and that was down to Kelly Sugarman, who's in charge of the Wyoming colorectal cancer screening program. And there are resources available for people who may or may not be insured, and our state is one of the lucky states who has excellent funding and resources to get screened if you're unable to get screened. You were always happy to talk to people in the office about this enrolling and put them in touch with Kelly. A great person, a great resource. So very fortunate in this state to have a well-funded cancer screening program. Our open access colonoscopy page has been very helpful. People can schedule this without a primary care physician. You basically go in and you fill out your intake form, and a nurse gets back to you based on your situation. We may be able to just get you in for your cancer screening without an appointment. For more complicated issues, we're always happy to see people in the office and discuss their particular situation and discuss their situation in relation to their medical history in relation to insurance. We just want to get people taken care of. This is another patient. Maureen was a great person. I think her story is a little bit different than Jamie's, and I think that you'll find that she's exceptionally frank and a really lovely person who had a difficult situation, but a very positive person, and has done very well. But I think that her story is a little bit different than Jamie's, and I think that it's important to hear every patient's particular kind of journey through the screening process and how that came about.
Hi, I'm Maureen Karawatzis, patient of Dr. Wieman's from December of 2019, and I don't know, maybe about a month ago he called and invited me to participate in this event. I gotta be honest with you, if you told me a few years ago that I would be participating in this event and sharing my experience about my first colonoscopy, yeah, I would have told you you had lost your mind completely. And yet here I am, sharing with you. So, a while back I passed that milestone birthday that a lot of us don't like to talk about. I'm one of those. And I should have gone in for my first colonoscopy, and I didn't. In fact, I put it off for quite a few years, and shouldn't have. And I don't know why I kept putting it off. Sure, I was busy like the rest of us, but I wasn't that busy to not see about my health, right? Well, so December of 2019, I finally cowboyed up and called Dr. Wieman's office, made my appointment, got my prescription, went in and had it filled, and I gotta be honest with you, it wasn't as bad as I thought it was gonna be. In fact, it really wasn't bad at all. You drink 2 small containers of this stuff and a bunch of water, and okay, so yeah, you spend the night in and out of the bathroom, but not anything a bad piece of fish hasn't done to you at some point or another. So the procedure itself, well, it went really, really well. In fact, quite honestly, I don't even remember it. But what I do remember is waking up and being told I had colon cancer. And you know what? I'm pretty sure that would not have been the outcome if I'd been taking better care of myself and had had my first colonoscopy when I should have, back when I hit that milestone age. So what I really want to share with you today is don't put it off. Don't be ridiculous like I was. Just get it done. You'll be so glad you did. And honestly, it's just so simple. So we have a wonderful hospital here. We have wonderful doctors. In fact, if Dr. Wieman hadn't been so wonderful, believe me, I wouldn't be here singing his praises and the praises of the hospital. So anyway, I guess that's just all I really needed to share, and thanks for your time.
Yeah, I think, so you can see that we have two different situations, and I think that we still have 2 good outcomes, and I think we're all very grateful for these patients to participate tonight, and I'm glad for their results. So we're going to kind of move along. This is
If I
Yeah.
could add something there.
Great.
I think Maureen brings up a really good point in that it's very normal and natural for folks to be really anxious about having that first colonoscopy. And I think everybody has a joke or something that you throw out when you hear the word colonoscopy, because we react and deal with things that make us anxious by trying to make light of it. I know I do. But it's really important, I think, to everyone on our team, whether it's the anesthetist, the surgeon, the nurses, the tech in the room. It's really, really important to all of us that people have a good experience. And I tell the people this all the time, and that it's normal to be a little anxious. Know that you're going to be in really, really good hands. We're going to treat you like we would one of our family members. And it's so important for folks to have a good experience with a colonoscopy so they'll come back when they're doing 5 years or 10 years. And I feel really strongly about that, in that 20 years ago, 30 years ago, when the technology and the scopes wasn't as good and the prep wasn't as good and the
CO2
medicine that we gave you to make you sleepy wasn't as good, everybody knew somebody else that had a bad experience. And you heard about that bad experience at work or at school or at church or at the grocery store, and that one bad experience would turn into 20 people that said, I'm not doing that.
Yeah.
If my friend Mary had a bad experience, then I'm sure not going to do that colonoscopy. So I don't want anyone to have a bad experience, because I want them to come in and have their colonoscopy. I think you guys would probably agree. It's much more enjoyable to interact with folks and see them and take care of them during a colonoscopy than it is to have to talk about colon cancer. And colonoscopy is our best tool to prevent colon cancer. So,
Yeah, I mean, I agree. I think you're right. I think that the things have changed, and just like Maureen said, I always kind of discuss it, say, the actual procedure itself. Once you've done your prep, I have a few recommendations on the prep, having done it a few times. If you drink it on ice and you drink it with some Sprite, it just tastes like cold Sprite. And then the actual procedure itself is you come in, you get your IV, you fill out a little bit of paperwork, you kind of lay down, and then you wake up like you've been watching Netflix, and now you're on episode 4 and you're on episode 1, and then
Right.
that's pretty much it. We rehydrate you and give you some IV fluid, and that's it. And we want you to have. I totally agree. The main thing is to have a good experience, so it doesn't preclude you from doing that in the future. And I think that the things have gotten a lot better. We use CO2 now. People don't feel very bloated. The anesthetic is so much better. I think people really pay attention to, the anesthesia is so good now that you really wake up pretty reproducibly. I've had colonoscopies back when they used air, and I remember waking up very bloated, and nothing. I have virtually nothing now. So yeah, I totally agree. Any comments, Justin?
I think another takeaway too is the screening age of 45.
Yeah.
Younger diagnosis, and trying to improve better outcomes for younger people. We do see that from time to time. Some young person comes in for their first screening, and we find positive results there that we would have missed if they would have skipped it. So at 45, I think that's a big change.
Yeah, and insurance has gotten a lot better. And you say, people now who are getting, the American Cancer Society came out with the guidelines of 45, and there'd been some perseverating about the insurance coverage, and I think that's resolving. Justin makes a good point that, I think the idea that colon cancer is an old man's disease, and that's simply not the case. The rate of colon cancer is climbing in a younger population where it's declining in people over 50, and it's not clear why that's happening. I think you can probably jump in, but just anecdotally, when we see people for diagnostic colonoscopies, and we whether it's for bleeding or for diarrhea or for other things, we don't tend to find a whole lot less. We tend to find polyps at generally a similar rate, is what I would say.
Right.
I mean, you can differ if you think, but what do you think, Jake?
Well, I agree with you guys. I think it was huge that insurance now is covering, and that the screening recommendation has moved to age 45. I'm 46, my wife's 46, and we'll both have our first colonoscopies later this year. And I'm a little excited about that, just because I've seen in the last 3 to 5 years, I've seen enough patients around my age or even a little younger than me that have had colon cancer and polyps. And it's a little bit of a wake-up call to me that, I'm now in the age group, and like you said, it's not an old person's disease. It's very much alive and active in folks that are in their mid-40s and early 50s. So I think that the other take-home from what you talked about earlier is that even though COVID threw a big wrench into folks' plans to do colonoscopies a year ago, it's super, super important not to let that slip by for another 3 years or 5 years or 10 years. It's really important to get caught up now on not only your colonoscopy, but your mammogram too, that you might have missed.
Yeah, absolutely.
Last year because of COVID. So cancer's still there. It's just, if we're not looking for it, we're not finding it. And those are our best tools to find it, and find it early, which is so critical.
Well, yeah, your overall 5-year survival is directly based on the stage that you get your diagnosis. So if we're finding colon cancer later, then the likelihood of needing chemotherapy, a larger surgery, radiation depending on where the lesion is. And really, when we want to do screening colonoscopies, we really don't want to find cancer. We want to find pre-malignant lesions that can turn into cancer. That's the idea. And then we can remove those so they don't perpetuate. The average time from polyp formation to cancer is 4 to 6 years. Now that's an average time. So that doesn't represent a particular individual. Maybe you have a polyp that develops at a faster rate. And that's how we develop screening guidelines. So like you said, and kind of the data would bear out, we have to catch up, and we have to continue screening people who are maybe at the age of who are getting out of the window to be screened, because those people are going to have cancer. And if we don't do that, we're going to see a lot more advanced disease and a worse outcome for people. I think when we were looking at putting this together, I thought that it maybe wasn't going to be as pronounced, and it's pretty disappointing to see how that played out. I would also say that one of the one of the things that we've seen, in this town, Teton Gravity Research did a great film on two young men who had colon cancer, and I would recommend everybody watch that. I think that that is something that when I saw that, I think that really is one of the more eloquent films I've ever seen. And if it doesn't make you cry, I always say you should get a DNA test to make sure you're a human being. So we're going to move along a little bit. Would you grab that?
The other thing that we wanted to talk into that kind of ties into the services we offer for colonoscopy is a newer offering that we have and a new tool that we have at St. John's, and that's the Da Vinci surgical robot. It's really a phenomenal piece of technology that allows us to do really effective, safe, and efficient surgery, not only for the colon, but for a lot of other common general surgery problems that we see as well. The Da Vinci robot's been around for a while. The first generation was developed and rolled out in 1999, and then the next generation rolled out in 2006. A newer generation was actually the one that I trained on, rolled out in 2009. And now our current generation is the Da Vinci Xi, and it rolled out in 2014. This, just like any other technology that we see, whether it's a smartphone or cryptocurrency or any of the other new developments that we've seen in our world, the next generation is just right around the corner, and I'm kind of excited to see what advances and kind of new features that's going to bring to the table for us. The Da Vinci robot has really a lot of advantages to either open surgery or laparoscopic surgery that we do as general surgeons. And I think it's important to understand that the principles of surgery, having good exposure so you can see the body part that you're working on, operating with minimal bleeding, having good sterile technique, and good technical skills of actually doing and performing the surgery, those principles stay the same whether we're doing the surgery open, laparoscopic, or robotic. The advantages of robotic surgery are really quite a few, and we're going to go through some of those. The first, and kind of selfishly, I think one of the first big advantages to the robot is it's much more comfortable for the surgeon in that we're able to be seated at a console, in a comfortable chair, in a comfortable position, and we're able to really focus on the surgery because there's no point in the surgery where you have some back pain or neck pain or you need to stretch or you have a cramp or something that might distract you a little bit from the task at hand. So from a ergonomics and a surgeon comfort standpoint, it's a big improvement, and something as I get older and look at having as long a career in surgery as I can have, it's kind of a big thing to have a tool that's going to help me take good care of people longer. One of the other interesting things that we can do robotically that we're not able to do with open surgery or laparoscopic surgery is that you can see a picture here on the left is what a normal segment of colon would look like through an endoscope or a laparoscope. And then the picture on the right, that patient's gotten some dye that stains and turns green under a certain type of fluorescence or a certain type of lighting that the scope provides. So green means that segment of colon has excellent blood flow. So with open surgery or laparoscopic surgery, we can only look and tell that that's a piece of colon, and we can speculate based on the color of the colon that it's got good blood flow. With the robot and this fluorescence imaging, we can actually test that and see it real time and know that segment of the colon is healthy and has an excellent blood supply, which is pretty key to our ability to do safe and effective colon surgery. It can also help us find structures that we want to make sure that we don't damage or injure. here's a picture of the common bile duct and the right and left and common hepatic ducts, which are ducts that live very close to the gallbladder. And during gallbladder surgery, we want to find and clip and divide the cystic duct, which is the duct that drains the gallbladder, but we try and protect these other ducts at all costs. It's kind of a big deal to damage or injure one of these important main bile ducts. And with open and laparoscopic surgery, we use landmarks, sometimes we use our fingers, and we use experience to see and find these ducts and protect them. But with the Firefly technology, we can actually make them light up and see exactly where they're at, and it's just another tool to help us be as safe and as effective as we can be as surgeons. Here's another structure. The ureter is the hollow tube that carries urine from the kidney to the bladder. And particularly during colon surgery, this is a structure that's very close to parts of the colon that we're going to be working on. So with open and laparoscopic surgery, again, we'd use the landmarks and our knowledge of anatomy and experience to find the ureters. Sometimes in folks that had inflammation or infection or cancer, sometimes those ureters can be difficult and challenging to find. But with the Firefly technology that the robot brings to the table, we can very rapidly find and assess the ureter and make sure that we protect it and don't injure it during the surgery that we're doing. Besides the fact that the robotic camera and scope allows us to do the Firefly imaging, and it truly gives us a much better picture than any other scope we have in our toolbox. I tell folks a lot that it's the difference between watching a movie in 4K high def versus watching it on a tube TV with a VCR like we watched when we were kids. It's a very remarkable, kind of a wow moment when you see the difference between the clarity of the screen and the colors and the crispness of the picture that we get to see. But another really important function and feature of the robot is that the instruments are wristed, meaning that when we do laparoscopic surgery, it's basically like operating with chopsticks. And there's an instrument, whether it's a grasper, which grabs or holds tissue, or a pair of scissors. It's like having a grasper or a pair of scissors on the end of a chopstick. So we have to move those chopsticks quite a little bit to make the instrument move. And the instrument's pretty straight and rigid. With the robot, the instruments are wristed, and they can bend and twist and do things that I can't even do with my own hand and fingers, which allows us to do some things with suturing and dissecting to be a whole lot more accurate and a lot faster and more efficient than we would be with the other tools that we have in our toolbox. So we see here Dr. Wieman is going to sit down at the robotic console, and this is where he actually controls the robot. I think it's an important thing. We talk about the robot a lot, but this robot is not like R2-D2 and C-3PO that can go off on an adventure and get into trouble and think for itself and do for itself. The robot is more of a remote controlled type of an apparatus where Dr. Wieman is seated there at the console, and the robot only does what he tells it to do. So he uses the instruments or the controls that he has in his fingertips to provide input to the robot, which then translate that to the patient. You can see here that he's tying a knot, and this is a simulated knot inside of a simulated patient, but I can tell you from experience and also just watching him that this is so much more smooth and fast and efficient and comfortable and accurate than doing this with a laparoscope, wouldn't you say, Eric?
Yeah, I think that your economy of motion is so increased so much. You know, we can all drive a car without power steering, without a backup camera, without anti-lock brakes. It can all be done, but nobody's going back to using that technology. So I think that the things that we're able to do now are really unlocking a lot of what you're going to see in the future. This is really the platform where surgical instrumentation is going to be developed. It's not going to be separate from the robot. There'll be some sort of derivative driven through this through the Da Vinci robot. It's very exciting. The last time this type of development really existed was 30 years ago when they transitioned from open to laparoscopic surgery, really opened up minimally invasive surgery, and this is just a next great iteration. So we're very fortunate to have this, fortunate for us to be able to provide this for our patients, that the hospital has supported us as well as the foundation. We're all could not be more excited about it. So I think that as in addition to what we do as surgeons, we use it for a lot of different things. We'll be using it for colonic surgery, hernia repair. Dr. Jorstad, who's not with us tonight, does a great job with his bariatric sleeves. This will be a major advantage, working in the hiatus, high up in the chest where your esophagus meets your stomach. A lot of times these patients have a hiatal hernia that has to be repaired in concert with his bariatric procedures. That kind of is a natural progression into our anti-reflux surgery. Maybe you can talk a little bit about the progression of anti-reflux surgery, laparoscopic procedures compared to a robotic version of this procedure.
I think I've had an opportunity to do a few anti-reflux surgeries on the robot, and it's always been an operation that I've enjoyed an awful lot. I think that the one part that I've never really enjoyed about anti-reflux surgery is that in general they typically take me an hour to an hour and a half to do, and with laparoscopic instruments I had to stand there for an hour and a half like this, and I would have some pretty incredible neck pain and back pain and shoulder pain when I was done with that. And it was always a bit of a grind for me during the case to stay laser focused on the patient and the surgery when you don't really feel good in that position for that length of time. And the robot changes all that. Besides having the better picture, the better instruments, I can really focus on what I'm doing, and I think do a superior job because I'm comfortable while I'm doing it. So I think it's kind of a game changer in that department as well. In addition to robots being used by general surgeons like we do, our urologists are also going to be able to use this to do kidney surgery and prostate surgery. And the gynecologists in town will soon be using it for hysterectomies, which hospital that I came from in Kansas was very impressive. The outcomes that, women would go home the next morning or sometimes the same day as their hysterectomy. And it'd be hard to think about that or even dream of that 10 years ago or 20 years ago for sure. So we're really excited about what those other surgical colleagues that we have will be able to do with the robot as well.
So we did have some questions submitted as far as colon cancer screening in the time of COVID. And I'll go ahead and read some of these questions. First question is, do I need to be screened for COVID or show proof of COVID vaccination prior to screening colonoscopies?
At this point, and actually throughout coronavirus, the hospital has done a great job of providing point of care coronavirus testing prior to your screening endoscopy or screening colonoscopy. So the issue of that's how we're addressing that. So we know in real time, what your coronavirus situation is, and that helps a number of things. That helps our staff, that helps all the other patients in the hospital, and that helps people who are thinking about getting screened have some peace of mind that we're doing the most that we can that's humanly possible to make sure everybody is safe. because a lot of this is about your perception of proceeding with your screening, and we want you to know that we're doing everything we possibly can to make that as safe a procedure as possible, and to remove that as an element or a barrier to you getting your cancer screening, really.
Great. Next question. Well, what is the average cost of a colonoscopy?
That's a great question. And honestly and truthfully, cost as it pertains to medicine is a complicated question. I think that the important takeaways for that question are, if you have health insurance and you're of the screening age, then you should be covered. All the major insurers are covering screening colonoscopy in that 45 to 80 age group. Certainly, if you have any questions about your particular insurance, call our office, and we have resources and folks there that can help answer that question as it pertains to you and your particular situation and your insurance. For folks that don't have great insurance or don't have insurance, there are also some really important resources, and Eric alluded to one of these earlier with the Wyoming Cancer Program, but we have some community resources through the foundation and some other resources available to help folks get their screening exams done now, even if they're not insured. And I think that's important for folks to understand, and I hope folks will utilize that, just because on one hand, I get it. It's difficult. It's having to ask for help. But it's important to know that the help's there, and it's a whole lot easier, and it takes a lot less days off of work and out of your life to have a screening colonoscopy than it does to have a colon cancer discussion and an operation and a recovery 5 to 10 years down the road. So I really, super important for everybody, irregardless of insurance and all that other stuff, to get it done. And we've got the folks and the resources to help.
Good. So how often should you have a colonoscopy, and does this vary by age?
I think I'll take that question. That's a good question. So when we talk about generalized colon cancer screening, and we talk about the age of 45, that's for average risk people with no family history and no clinical symptoms. They're not having diarrhea, they're not having abdominal pain, bleeding, or anything like that. What that is that's a baseline. So although we talk about screening guidelines, that's covering a population, and that's not exactly specific for individuals. And that's why we encourage people to fill out something like the open access colonoscopy form. If you fall into like a low or average risk category, that would be the age of 45 in general. For these other variations on that, that's something to talk about within the office, because everybody's family history is a little bit different. Sometimes people are having minor symptoms. It's just, that is kind of a case-by-case basis. And a lot of times people, if they do have a family history, we use that time to address, do you need some genetic counseling through our oncology department in the Huntsman Cancer Center? Have you been risk stratified to be genetic tested? So it's not necessarily just that you need to have a colon cancer screening because of family history of cancer. You need to really understand the context of your own cancer history and what can be done to anticipate problems for you or your children or the next generation. So I would say, 45 is a basic guideline. The age of 80 is a basic guideline. Now, the reason I use 80 as a basic guideline is because, in general, people's comorbidities at the age of 80 kind of outstrip the anesthetic risk. However, in this community, and in western Wyoming, people tend to be fairly hardy. So they're living a very active lifestyle no matter what they're doing, even until their 90s. So it's all conditional, especially the people who are now out of the age 80 screening window that didn't get their screening colonoscopy. You have not escaped the problem. You've kind of just escaped the screening, really. So we'd encourage anybody who has any questions about their particular situations to talk about it. And we spend a lot of time talking with people about their particular needs.
I would agree with that. Screening very much is it's not a one-size-fits-all kind of thing. It's very much a very personal, specific recommendation. But I think kind of generally how I typically present this to folks in the office is that folks that are at low risk or folks that don't have a personal history or a family history of colon cancer or polyps, and generally those folks could have a colonoscopy every 10 years, beginning at age 45 ideally. Folks that are at high risk of colon cancer would be those folks that have a personal history or a family history of colon cancer or polyps, and generally we would recommend that we would do screening more frequently in that group because they would be more likely to develop polyps and cancer. And the general recommendation would be that we do a colonoscopy at least every 5 years in that age group. Now there's some other variations to that, and some people that have a larger number of polyps or larger polyps, we might recommend that we do those every 3 years. Typically, folks that have colon cancer surgery would have a first colonoscopy a year after colon cancer surgery. So there are some variations, but generally, low risk every 10 years and high risk every 5 years is a pretty good guideline or rule of thumb, I think.
Yeah, I agree. And we have there's some guidelines set up by different societies that, based on things that Dr. Breeding is talking about, based on your family history and your personal history of polyps and cancer, the number of polyps we find on a colonoscopy, the size of the polyps we find on a colonoscopy, and the type, that also plays into it. Not all polyps are the same. And additionally, some of these guidelines are a dynamic process. For example, because now people are being screened so much better, someone whose father may have had cancer at 45, maybe they went ahead and got screened and just had a bunch of polyps. Well, that doesn't mean we don't actually want the older generation to find cancer and use that as the marker of when you should be screened. It used to be 10 years below the age of the relative was noted to have cancer. But if someone has a lot of polyps and they're being screened, they're not going to develop cancer. But that other person, the next generation, should still be screened at the age that they're finding a lot of polyps. So it's a dynamic process. And again, for specific questions, those are generally best answered in person because, as Jake said, screening guidelines are population-based screening, but they're not applicable in every single sense. And they're really for an average to low-risk population. For higher-risk people, those people should come in and we should talk about the particular situation.
So next question really refers to screening. Are there simpler, quicker, or less invasive methods of screening for colon cancer?
There are a few, and I think the ones that folks are most familiar with would be the FIT test, or the one that you see fairly frequently on TV recently is the Cologuard test, which has got the box, the animated box that tells you to get the test. Those are both stool tests that look for DNA that can be related to colon cancer and can also look for blood. Those are great tests in folks that fall into that low risk colon cancer category. So folks that don't have a personal or a family history of colon cancer or polyps would be good candidates for that. The thing to know about that test is if you have a positive result, then that would prompt us to recommend a colonoscopy. So I've always been a little biased, and not biased by the fact that I do colonoscopy, but biased by the fact that one of the big advantages I see to colonoscopy, besides being a screening tool, is if we find a polyp or find a problem during that colonoscopy, we're able to do something about it at the same time. A polyp is just a small abnormal growth in the inside lining of the colon that over typically a 5 to 10 year process can grow and develop into a colon cancer. I would say that the average size polyp that I find and remove is about 5 to 6 millimeters in size. They are very, very tiny. But if we can find that tiny polyp and remove it when it's 5 millimeters, we can prevent it from becoming something that's large enough to cause a blockage of the colon or abdominal pain or bleeding or other kind of symptoms of a bigger problem that can be much harder for us to treat and much harder to achieve a cure.
And how are those polyps removed?
There's a couple of ways that we can do that. The way that we do it most frequently is, and I think folks from Wyoming will identify with this, but we basically place a little metal lasso around the base of the polyp. We tighten the lasso, and then we apply a little bit of gentle electric current to that lasso, which creates heat. So I like to think about things pretty simple, but it's like having a cheese slicer that cuts through the cheese, only this cuts through the polyp, and that heat seals any blood vessels there, so it's a great way to safely remove a polyp and not have any bleeding.
That ties us into our next question. What are some risks associated with colonoscopies?
There aren't a lot, but there are a few. The main risk would be a risk of bleeding and a risk of causing a puncture or perforation during the colonoscopy. Those are kind of the big surgical risk. The most recent literature that I have read, and what I quote folks, is that should be a less than 1 in 1,000 risk of either one of those two things happening. I think, again, I'm going to show a little bit of my bias as a general surgeon, but I think one of the important things that general surgeons bring to the table, besides being skilled endoscopists, is that we're very familiar with diagnosing bleeding and perforations in bowel from other problems. So we're, I think, pretty good at finding those and figuring that problem out early. And then we have the surgical skills, both open and laparoscopic and robotic, to be able to address the problem if it happens. I'm real careful, and I always tell folks that, we do everything we can, and we're very focused and very careful during the procedure from preventing those things to happen.
Yeah.
If they were to happen, then we're going to find it and we're going to fix it safely and efficiently. It's not unlike someone that if someone had to drive back and forth to Cheyenne for work every day, at some point in time, they're going to have a car accident. Whether it's a blizzard or the wind blows them off the road, or they hit a mule deer or an antelope, or they blow a tire, at some point, if you make that trip enough times, you're going to have an accident. And it's not dissimilar to colonoscopy. I think if Eric and I do enough colonoscopies over a career, at some point we may have bleeding or have a perforation. My goal is to do everything I can in my power to prevent that. And I think Eric would probably agree with that and say the same.
And I agree, and I think if there's an issue, manage the issue and take great care of people, and that'll be that. I think one of the other nice features now, really endoscopically, when you're removing these polyps, the technology in elevating some of these polyps off the wall, we take a very, very, very small needle and we inject some saline, and the saline will create a bubble underneath this polyp, and then we can safely put that lasso around the polyp and remove it. And that does two things. One, it separates out the polyp from the wall of the colon, which is helpful in preventing the actual traction injury to the wall of the colon. And then two, disseminating the electrical current, acting as a buffer through the wall of the colon. That to me has been a great adjunct in some larger polyps that we find. Sometimes it allows us to remove precancerous lesions that previously would have had to been removed surgically, but now we have the endoscopic techniques to remove those at just the basic colonoscopy visit. So I agree with you. We provide a situation where if there is frankly, no matter what we find on our colonoscopy, whether that's cancer or whether we find some bleeding, we have the skill set to manage all of the issues at the same time.
Right.
And then what are the latest findings in preventing diverticulitis flares?
That's a good question. I think, so diverticulitis is an infection in the wall of the colon that occurs when folks have diverticula. And diverticula are little pockets that form in the wall of the colon. They're very, very common in our country, primarily because as Americans, we tend to eat a lot more red meat and processed foods than other parts of the world. Other parts of the world tend to have more grains and fruits and vegetables and nuts as part of their diet, so they have a higher fiber diet than we do. With a lower fiber American diet, our colons have to generate more pressure to move the stool through the length of the colon, and that increased pressure causes those little pockets to form. I think the best preventative strategies are to be conscious about your diet and remember to eat your fruits and vegetables and whole grains to increase your fiber intake. A fiber supplement certainly doesn't hurt anything at all. But I think it's been about 7 to 8 years ago now that this study was published, but for a long time we would tell folks that had diverticula that you shouldn't ever eat anything with a seed or a nut in it because you'll get diverticulitis. And I think the study that was presented at the College of Surgeons meeting, I think it was about 8 years ago, did a really good job of completely blowing that old myth out of the water. In that study showed that normal consumption of anything with seeds or nuts is healthy and does not increase your risk of diverticulitis. And when you think about it, it's really hard to eat a high fiber diet with lots of fruits and vegetables and not eat something good with a seed in it. Right. I mean, virtually everything in your garden has a seed of some size. And you know, the only person that would be, you know, if you're eating popcorn 3 meals a day, 7 days a week, then maybe you have a little higher risk of diverticulitis. But I don't know anybody that likes that much popcorn.
No, I think you make a good point. I think that on one hand you have, you know, obviously our diet of Western diet of processed food and maybe a little bit too much meat, creating this high pressure system. You can't tell people that you can't eat seeds and nuts and then tell them not to eat processed food. You know, that's a mixed message, and like the message really should be try to eat a healthy, balanced diet. You know, consume fiber in whatever form you can, whether that's a fiber supplement, whether that's, you know, roughage in your diet. But I think that also in regards to diverticulitis, we've really shown that. You know, it used to be the tradition that if you had 2 hospitalizations with diverticulitis or severe episodes, then you required surgery. And I think more and more, you know, we try and manage the patient as opposed to a didactic number. Right? Is that person not able to go to work because they're having so many episodes of diverticulitis that they basically can't work? You know, is that person been severely disabled? You know, so again, while we use guidelines for specific things, patients are individuals, and we try and address a patient's needs to their specific medical problems. So Dr. Google is great for some things. It's great for providing you a broad spectrum of information. It's not very helpful in making your personal medical decisions. And I think then that people have had enough experience with that kind of situation with the internet that now that although it gives you a lot of information like nuts and seeds, should I be doing that? Right. The best way to really figure out what is going on in my medical situation and with the information I have, how do I act on that? The best way to mitigate these issues is to go and actually talk to a surgeon about what your knowledge base is and your condition, and we'll find the solution that's right for you.
So the last question relating to the Da Vinci robot is, what kind of training do you have on a Da Vinci robot, and how does the learning curve compare to an open procedure?
Well, I think I get to ask you a question since you have and I'll answer your question with a question to you.
Okay.
I think that I would say the Da Vinci robot is it makes learning very easy. If you already have a very good minimally invasive skill set, it makes it a lot easier. And to kind of go to elucidate this, I'll say, you know, the technology that has improved minimally invasive surgery with the robot, you know, Justin, you're a skier?
Correct.
Do you use skis that are 2 meters long anymore?
Technology has changed. No, I don't.
Do you know, there's a pair of skis on Corbett's, I think, that says deep powder, and the skis are so narrow that they can't put deep powder on one line that has to say deep powder. And I don't see anybody skiing these deep powder skis anymore. And I think that that's the situation that we have basically with the robot. You have better technology now. What do you think? So since you've been involved in about almost 24 robotic procedures, what do you see as the change?
I see it's a lot simpler as far as the OR staff. You know, it's really interesting how much you can do with just a couple instruments inside the abdomen versus instruments in and out, and just switching hands. It just kind of simplifies everything. You know, I feel like you can really get in there, see what you're working with. The visualization's really nice. And I think it's really helped our outcomes already. You know, as far as the learning curve, seems like your skills translate straight across. It just, you know, you get used to moving the robot around, and I see that the surgeries are coming along very nicely, and our patients are doing very well.
Great.
I agree. I think we learned as surgeons and kind of cut our teeth on open surgery. I mean, that any resident, probably most of my first year was learning how to do open surgery. And then you take that a step further with, okay, now I'm going to learn laparoscopic surgery, which is the same ideas and principles and rules with different tools to do the operation with. The robot's now just a much better tool than the other two. But saying that, like we've talked about with some of the other things we've discussed tonight, is that surgery is still a very personal recommendation. It's not a one-size-fits-all. For two patients with the same problem, I might recommend open surgery for one and robotic surgery for the other based on some other factors and other history that they might have. So I feel like the robot makes me the most complete surgeon that I can be because I've got open surgery and laparoscopic surgery and robotic surgery, so I can make a really customized and personalized recommendation for each patient.
Yeah, and I think to segue into kind of our colon cancer, our colorectal cancer screening situation, you know, our goal is to provide care all the way from the beginning, from basic screening to if you have a small polyp, we remove that. If you have a larger polyp, we may or may not be able to remove that with the endoscope. And if we can't remove it with the endoscope, we may be able to remove it. The polyp, actually, sometimes we do polypectomies. We could even do that with the robot. Sometimes if it's such a big lesion that we'd have to remove part of the colon, we can do that robotically. But we see you from the beginning of your treatment to the end of your treatment. If you need chemotherapy or radiation, we work with our associates at the Huntsman Cancer Center, and we have a great relationship with them. So we really want to do our best to take care of the patient from the beginning to the end. You know, we've had great support from the hospital and the foundation, and I think that the future is only brighter here in Jackson.
I agree.
Great. Well, that wraps up our questions. Thank you guys very much for tuning in.
Thanks for joining us.
Thanks, guys.